Hello again. This is my continuation of talk on the narcolepsy and the workup of excessive daytime sleepiness. So we talked about narcolepsy briefly last time, and I mentioned that there are four different things that are associated with narcolepsy. One, of course, is excessive daytime sleepiness, which is present in almost everybody, cataplexy, which is a sudden loss of muscle tone, and that's the second one. The third one is sleep paralysis. That means people, when they wake up, they find themselves unable to move, but they know everything which is going on and can see and hear. And last but not the least was the hallucination that occurs while you are falling asleep or when you are waking up. So those are the four things that are associated with narcolepsy. But excessive daytime sleepiness can also be because of a number of other conditions, including, of course, sleep apnea that we talked about before. It could be also due to the medication use like narcotics, sedatives, tranquilizers. Many other medication can also cause it, including some beta blocker, which are used by cardiologists, some anti-anxiety medications, some other medications that are used for other purposes can also cause drowsiness. So the medication use is also another common cause. Absolute deprivation of sleep due to work and poor sleep habits and hygiene can also contribute to it. And of course, the sleep apnea that I mentioned. There's also a condition which is called excessive daytime sleepiness of unknown etiology, or called idiopathic hypersomnolence. Idiopathic means we don't know the pathology. We don't know what happens. In fact, recently one of the medication that was approved for cataplexy / narcolepsy has been approved for idiopathic hypersomnolence by FDA just last week. So the testing during night will give you the answer as far as sleep apnea is concerned or poor sleep is concerned, but it does not give you the answer about the diagnosis of narcolepsy or idiopathic hypersomnolence. So to confirm the diagnosis or to aid in diagnosis of narcolepsy, other than history, a test is performed during daytime. And this is what I was talking about it last time. It's called maintenance of sleep. So there are normally this test is performed after an overnight sleep study where we are guaranteed that there was at least 6 hours of good sleep, and then during daytime we do a test. So 2 hours after somebody has had a sleep study done, had breakfast, we do 20 minutes naps and a test, total of 5 maximum. So there's a distance between the two naps. So basically, let's say you finish sleeping at 6 o'clock or 6:30, you eat the breakfast, then at 8:30, you're still hooked onto the monitors of the brain, and you're put in a recliner with a dim light or no light, and study is done to see if you fall asleep. So if someone falls asleep in a very light stage of the sleep, which is stage 1 or 2, that is recorded. If somebody has a REM sleep, that is also recorded. And the duration, the latency after the lights are turned off is monitored. So if somebody falls asleep in less than 8 minutes in a nap of 20 minutes, and the sleep onset is stage 1, 2, or 3, but not REM, then that's considered abnormal, and that would be recorded as an abnormal sleep latency. In narcolepsy, people fall asleep in less than 8 minutes in a 20-minute nap, but they have REM sleep onset within that time. So there are two different things. One is falling asleep in less than 8 minutes or falling asleep more than 8 minutes time latency. If somebody falls asleep after 8 minutes of lapse time from starting the test, we don't know the significance of that. But if it is less than 8 minutes and there is no REM sleep, then it is called idiopathic hypersomnolence. If there is a REM sleep onset in less than 8 minutes, then it's considered narcolepsy, or diagnosis of narcolepsy is aided by this test. It's called SOREM, sleep onset REM sleep. So the narcolepsy is suspected when people have excessive daytime sleepiness or cataplexy or sleep paralysis, which also occurs in normal people, and hallucinations at the onset of sleep or waking up from the sleep. So those four quadrants are there. The confirmation occurs when somebody has REM sleep onset in less than 8 minutes during this MSLT test that I just described. Now again, we have to have minimum 2 out of 5. Naturally, if there's only 1, we may have to say, well, was it there or not? And there are some faults with this particular test because number one, it doesn't tell you if somebody falls asleep after 8 minutes. All that it tells you is that they fell asleep. There is no significance. It is not good for younger kids because we don't have any standards for that. And lastly, the fault that I find is that people who have excessive daytime sleepiness because of their sleep habits may not be caught with this particular test or maybe wrongly stamped as narcolepsy. There are some drugs which also cause increased REM sleep. There are some drugs where the withdrawal of the drug causes the REM sleep, and that may be the issue while you're doing MSLT. Give you an example. Let's say somebody has a habit of going to the bed at 1 or 2 o'clock in the morning, quite common with teenagers, and waking up after 8 hours at 10 o'clock or 9 or 11 o'clock. If you happen to test them at 8 o'clock and then again at 10 o'clock, they may have a REM sleep which is natural for them, as that would be the part of their sleep cycle, because the strong REM occurs in second half of the sleep. So if you do it in a teenager who has the habits of going to the bed late and waking up very late, and I've seen some people that go to the bed at 2 o'clock, 3 o'clock, and then wake up at 11 o'clock. These are the people, if you do the MSLT in the morning, you're going to have abnormal MSLT. And that is going to cause problem. So essentially, you got to be careful when you do the MSLT. As I said, certain medication, for example, alcohol withdrawal can cause REM sleep rebound. There are other medications, antidepressants and others, that also can cause increased REM sleep. And if somebody has discontinued them, or they have taken it in first half and now this is a second half withdrawal type of thing, they will get it positive. So we do have treatment for MSL, we do have treatment for idiopathic hypersomnolence as well as narcolepsy. Number of drugs are used, including amphetamine. Are there other products similar to that? And of course, the modafinil is the standard one, which is non-addictive, has no withdrawal, and that can be used very successfully in these patients. Certainly, I'm not going to talk about the treatment of narcolepsy, but I talked to you about the 4 different things that one has to look for it and how to diagnose it with history and then with MSLT. Thank you for watching. I hope you like it and tell your friends. Have a nice day.